talk with you again in a moment. But now let's look further afield at how health services are provided in the more remote parts of the Territory, particularly to Indigenous people. The Katherine West Health Board was set up in the late 90s. It's run by Aboriginal communities and funded by both the state and federal governments. Its outstanding results in chronic disease management prove that Indigenous health can be managed effectively when a bit of flexible thinking's involved, as Margie Smithhurst found out.
With the rollout of Katherine West, we've actually managed to increase resources to a level where staff can actually concentrate on chronic disease care rather than be continuously busy with the acute stuff that's coming through the door.
Back in the early 90s, Andrew Bell, doctor, pilot and sometime wildlife photographer, had a dream of how he wanted medical services delivered to Aboriginal communities within the vast Katherine West region. He imagined a time when details of even the most remote patients would be readily available to health workers. Information would have to be fast, integrated and comprehensive. More than a decade later, it seems the Holy Grail is finally within his grasp.
We've now got very good information management with a fully networked electronic medical record, and any of our clients can present to any of our clinics, and the staff are working from the same electronic health record.
Just move up to immunisations. Do you have that there, Deborah?
Katherine West covers 180,000 square kilometres, stretching to the West Australian border across numerous Aboriginal communities and pastoral stations.
If somebody presents at any of our clinics, the staff know immediately what their allergies are, what chronic conditions they have, what chronic condition care they're due for, when their next ophthalmology appointment should be, when their next blood tests for their cholesterol or their blood glucose is due.
Almost all the Katherine West doctors now visit communities by plane after the service had great difficulties hiring GPs willing to live remotely.
When our last GPs left Kalkaringi and Largemanu, despite more than 12 months advertising, we were unable to attract resident GPs, and with discussion with our communities, we decided to go back to a model of having GPs based in Katherine but flying out to communities every week.
Arguably, it's the move away from a government-run model that makes the service so effective. A large number of the employees and all of the board are Indigenous.
Our whole organisation reports to a board that's elected by the communities. We report back to them on health outcomes, on finances, on employment. They sit on interview panels for staff. They help us make the decisions about who we employ.
The service is obviously doing something right. An audit of patients in the Timber Creek community places the service's management of chronic diseases above those of mainstream GP clinics.
We're actually more successful than the general practice average for Australia in achieving targets in cholesterol and targets in blood pressure. And we're actually now rising above the average with achieving targets for tight control of blood sugar as well.
Andrew Bell says the new information system has been vital in driving and measuring the quality of Aboriginal healthcare.
We're not the only ones doing this. Across the Territory, there's a very strong focus on chronic disease management in both the government and the community sector. And I think what we can confidently say is that with the level of care we're providing, we'll be seeing quite strong trends of improved health outcomes.
Well, Dr. Jeff Stewart has worked in remote communities for 10 years. He said